Good morning and welcome to Medicine Grand Rounds. Today it's really a pleasure for me to introduce Dr. Tiffany Lin, one of our own. Dr. Lin is a graduate summa cum laude in biomedical engineering from UT Austin. She then took her MD degree at an outstanding institution, UT Southwestern in Dallas, before undertaking internal medicine residency at Case Medical Center and Rheumatology Fellowship at the Cleveland Clinic. In 2016, we were delighted to recruit her onto the faculty as an assistant professor, and she also serves as Associate Program Director for the Rheumatology Fellowship Program. And credit goes to Kevin McCown for this outstanding recruitment. She has published and provided a number of abstracts over the years, including presenting in San Francisco, some of her work that she undertook as a fellow, I believe. She is an avid educator. Among the things she's doing, she's the assistant block director for the forward curriculum for the block on invaders and defense. She's a small group leader for the rheumatology section for the medical students. She's a live lecturer. She's a video lecturer. She's a PACE case facilitator for the forward curriculum. And all of these areas took significant work because they're new teaching assignments that she's played a role in developing. She's a rheumatology clinic preceptor for medical students and the course developer and primary instructor for the Rheumatology Diagnostic Skills Conference for the fellows. She also educates in the nurse practitioner and PA programs and is an avid educator for students, residents, and fellows, both on the consult service and in the clinics. She's also a very good citizen in terms of her departmental activities. She is on the Department of Medicine Rheumatology Fellowship Clinical Competency Committee and the Department of Medicine Rheumatology Program Evaluation Committee. Along the way, she's earned a number of honors, among them the Golding's Academic Award in Rheumatology when she was a med student at UT Southwestern, and the Adel Ascari Memorial Award from the Cleveland Society of Rheumatology during fellowship. She's established herself as one of our rising stars clinically and obviously in education, and we're really privileged to have her present Grand Rounds today entitled Spondyloarthritis, Effective Strategies to Put Out the Fire. Please join me in welcoming Dr. Lin.
Hello, everyone. I want to begin by drawing your attention to this photographic series taken over the period of 26 years. And you can see that the man in the left-hand side of the picture has a normal appearance. However, 10 years later, you can begin to appreciate actually some changes in his posture, exhibited by thoracic kyphosis and hip and knee flexion contractures. 10 and 15 years later, you can see progression to changes in his posture, leading to a forward position, a fixed position of his spine, and he requires ambulation with a cane at this point. The final picture on the right actually shows post-operative appearance of a hip replacement, and there shows to be some improvement in his posture, but you can still see that he has significant limitation in his flexion contractures and in his spine. You can appreciate the impact of these debilitating skeletal changes on his lifestyle and his daily functioning. But more difficult to identify here is the fact that he also has a heightened risk of cardiovascular disease, osteoporosis, and depression. Had he been able to receive effective treatment for his condition, especially earlier on, it would have altered the trajectory of his skeletal deformities and could have actually resulted in improved quality of life in this patient. So that leads us to the goal of our talk today, which is to improve the understanding of axial spondyloarthritis in order to facilitate the early diagnosis and treatment and impact long-term outcomes. So at the end of this talk, you will be able to apply a diagnostic approach for inflammatory back pain and recognize key clinical findings in axial spondyloarthritis. We'll be able to list recent advances in the understanding of the pathogenesis of axial spondyloarthritis, and we'll be able to describe established and evolving treatments for axial spondyloarthritis. I have no disclosures. And in returning to this photographic series, this was an individual who had spondyloarthritis, which is defined as a form of inflammatory arthritis affecting the spine and the sacroiliac joints, also known as the axial joints. It is caused by altered immunity. Up until the middle of the last century, these profound deformities were inevitable in these patients. But we now have the ability to identify these patients very early in the disease, but only if we have a high index of suspicion. We want to aim to identify all patients at this stage in order to make a big difference in terms of their treatment. And I'm going to give you the clinical tools today to help achieve this in the practice of patients who may still be undiagnosed in your own clinical practice. So to understand how we currently classify spondyloarthritis, we need to go backwards in history a bit. Individuals with this condition have been recognized for over 200 years, initially under the diagnosis of ankylosing spondylitis. It wasn't until the 1930s, with the advent of radiography, that the first X-ray findings were described. By the 1970s, the gene test HLA-B27, encoding major histocompatibility complex class 1, was identified, and it was clear that ankylosing spondylitis was actually a part of a family of interrelated conditions that were associated with skin, eye, and inflammatory bowel disease. The widespread use of advanced imaging techniques, including MRI in the 1980s and 1990s, actually led to identification of early inflammation in the absence of radiographic changes. As a result, the diagnosis was being made earlier and earlier in these patients, since we no longer relied on radiographic criteria to make the diagnosis. In fact, some of these patients actually never developed radiographic changes, despite inflammation for many years. And MRI was actually now able to identify these patients. So since 2009, we actually now classify all of these patients under an umbrella diagnosis of spondyloarthritis. And if they have spinal involvement, which occurs at varying frequencies depending on the subtype of disease, we specify that as axial spondyloarthritis. This includes the original diagnosis of ankylosing spondylitis, as well as 4 other forms that have the potential to involve the spine, including psoriatic arthritis, enteropathic arthritis, reactive arthritis, and undifferentiated spondyloarthritis. So how do we diagnose spondyloarthritis? We will begin by taking a closer look at back pain. So to understand the scope of the problem, we must recognize that back pain is a leading cause of primary care office visits. And when it comes to inflammatory back pain, 5% of cases are actually found to be due to axial spondyloarthritis. A recent study in 2012 actually found that there's a prevalence of this condition between 0.9 and 1.4% of the U.S. population. And that's about 1 out of 100 patients. That's actually quite similar to the prevalence of rheumatoid arthritis, another condition that we often see and treat. This is a small but not insignificant number, and we don't recognize it too often as such. Initially, the disease was felt to affect men 10 times more often than women, but with the advent of MRI imaging and other modalities, we've actually found that it's about 2 to 1 still in favor of men, or about 3 to 1 in ankylosing spondylitis, and about 1 to 1 in other subtypes. It has been well established that early diagnosis and treatment improves long-term outcomes in spondyloarthritis. So a history of inflammatory back pain is often suggestive of axial spondyloarthritis. And a 2009 study proposed criteria to distinguish inflammatory back pain from other forms of back pain. There are 5 criteria, which include age of onset, less than 40 years old, insidious onset of the back pain, improvement with exercise, no improvement with rest, and pain at night, especially in the second half of the night after the patient's been immobile for a long period of time. Meeting 4 out of the 5 criteria indicates a diagnosis of inflammatory back pain with a sensitivity of 77% and a specificity of 91.7%. Additional criteria that may be helpful to include also include morning stiffness greater than 30 minutes, alternating buttock pain, and a response to NSAIDs. Finally, it is important to know that while inflammatory back pain itself is suggestive of spondyloarthritis, By itself, it's still less than 80% sensitive and 80% specific for axial spondyloarthritis. So we're going to discuss the other components of making the diagnosis in the next couple of slides, starting off with a physical exam. So if patients are presenting with early disease, the only notable finding on physical exam sometimes may just be buttock or spinal tenderness. Some patients also develop loss of spinal mobility related to either the pain or limitation in the restriction of motion. And they may develop limitation in flexion and extension of the lumbar spine, as demonstrated in this photograph. In long-standing disease, they may also develop loss of lumbar lordosis and exaggerated thoracic kyphosis, as demonstrated in this image here. In order to stay upright, patients may actually begin to make corrections in their hips and their knees, which lead to the development of flexion contractures at these locations. And then if the costovertebral joints are involved in this disease, they may also develop a limitation in chest expansion and a restrictive ventilatory defect, making it even more difficult to exercise. The pathological correlate of these findings are caused by inflammation in the sacroiliac joints, which are located here in the figure on the right-hand side and located here over the patient. The inflammation can also progress to involve along the spine, and we call this spondylitis. The changes occur as a result of both bone destruction and abnormal bone formation. And you can see this radiographically in the sacroiliac joints. On radiography, normal sacroiliac joints demonstrate discrete, well-defined contours on either side of the joint, with an even amount of hypodensity indicating the presence of normal cartilage between the joints. In early sacroiliitis, however, there is an early disruption of the contour and associated erosive changes, as you can see here on the right-hand side. These are findings that occur due to bone destruction. Some of the patients lack erosive changes, however, in spite of having active disease, and the x-rays are normal in those patients, as seen on the left-hand side. These patients, however, may have MRI changes, which are highly sensitive for inflammation. This is a T2 fat-suppressed transverse view of the sacroiliac joints, demonstrating hyperintensity, representing bone marrow edema surrounding the sacroiliac joints. Patients with long-standing disease may also eventually develop X-ray findings consistent with late sacroiliitis, demonstrated here, where you see complete fusion of both sacroiliac joints and loss of the space in between. This is an example of abnormal bone formation. Similar changes can be seen in the spine, including erosions, syndesmophytes, which are fusions between vertebrae. You can see ossification of all of the anterior longitudinal ligaments, and if the disease is allowed to progress on its own, the natural history is that patients actually develop complete fusion of the spine, which we call a bamboo spine. This is a result of both the bone destruction and the abnormal bone formation. And these changes result in a number of issues. You can imagine that you would have restricted mobility in these patients. They also develop a restrictive ventilatory defect leading to restrictive lung disease, as well as a risk of osteoporosis and risk of fracture. So the classification criteria for axial spondyloarthritis we talked about came out in 2009. And they're mainly used to provide that we have a homogeneous group of patients to study the disease in. But it's also a helpful guide to make the diagnosis in the individual patient. And so to make a diagnosis, there must be the presence of inflammatory back pain, which we discussed in the criteria before, going on for at least 3 months in patients younger than 45 years old. And so in order to make a diagnosis, you need to have either X-ray or MRI findings of sacroiliitis and one clinical feature, which I'll show you in a moment. Alternatively, if you do not have X-ray or MRI findings of sacroiliitis, you could have a positive HLA-B27 gene test and 2 clinical criteria. And here are the clinical features. And I'm just going to point out a number of these which are more relevant. You can have enthesitis, which is defined as inflammation at the insertion sites of tendons, ligaments, and fascia. Most commonly, this occurs over the Achilles region or over the calcaneal insertion of the plantar fascia, but it can technically occur in any location where there's fibrocartilage. You can have dactylitis, which is swelling of an entire digit. You can appreciate in the image here that the fifth digit is entirely swollen. Some patients may actually present with acute anterior uveitis. This is inflammation of the anterior chamber of the eye. Patients who have this may present with redness, pain, blurred vision, photophobia, and if not treated promptly, they're at risk for glaucoma and blindness. There are also associations with psoriasis and inflammatory bowel disease. The last key point that I wanted to make here in this slide was that acute phase reactants are only elevated in 50% of cases. So this really separates it from other kinds of autoimmune conditions that we see, including rheumatoid arthritis, where we would more predictably expect those numbers to be elevated. In addition to the diagnostic clinical features, cardiac disease is actually quite common in these patients. Up to 10% of patients have conduction defects ranging anywhere between first-degree AV block to complete heart block. 10% of patients also suffer from aortic regurgitation, and the appearance of the aortic regurgitation in these patients is actually different than what we see in other forms. They often start with dilation of the aortic root, and pathologically this is associated with aortitis. Finally, because of the degree of inflammation, systemic inflammation in these patients, there's a higher risk of atherosclerotic disease, including ischemic heart disease, peripheral vascular disease, and stroke. And it's actually the leading cause of death in these patients. Patients with axial spondyloarthritis also have a higher risk of osteoporosis, which is associated with disease activity, and then also with reduced mobility and physical activity. Interestingly, fractures related to osteoporosis in these patients more commonly occur in the cervical spine compared to patients with senile osteoporosis that may have fractures more commonly in the thoracic and the lumbar spine. Finally, it's important not to forget that chronic pain is associated with sleep disturbance, fatigue, and depression. We need to make sure to acknowledge the impacts on mental health in our patients in order to proactively address them and provide them resources to cope. I want to make a few additional comments about axial spondyloarthritis in women. When compared to men, there's often a delay in the diagnosis. And this may be due to the lack of awareness in spondyloarthritis in this demographic group. And it may relate to the fact that it was classically thought of as a male-predominant disease, and with the advent of MRI information, we now know that that's not fully the case. Patients may also be misdiagnosed, and they may get a diagnosis of fibromyalgia, for example. And this in part may also be due to the fact that there's less radiographic involvement, as we discussed. Women as a group also appear to have worse functional outcomes when compared to men. Fortunately, there's no effect on the ability to conceive, no effect on pregnancy outcome, and no effect on neonatal health in these patients. However, the pain related to the condition may affect their ability to cope as a mother and a caregiver. So we need to make sure that we adequately support our women with axial spondyloarthritis so that they can complete their roles. So in summary, axial spondyloarthritis is a family of related conditions. Inflammatory back pain is a prominent feature and occurs as a result of both the sacroiliitis and the spondylitis. The diagnosis is made by a combination of either abnormal imaging findings or a positive HLA-B27 test with certain clinical features. And then important comorbidities include cardiovascular disease, osteoporosis, and depression. I want to move on and change gears to talk about the pathophysiology of axial spondyloarthritis and the recent discoveries that have been identified. It was previously believed that inflammation led directly to bone destruction and bone inflammation. However, the prevailing theory now is that inflammation leads to bone destruction and that the resulting damage actually triggers abnormal bone formation independent of the inflammation. Therefore, once you have bone damage, controlling the inflammation at that point may not necessarily prevent the development of abnormal bone formation. As we discussed before, this leads to changes in restricted mobility, restrictive lung disease, and osteoporosis. However, if we can treat the inflammation early on before it leads to any damage, we may actually have a chance of avoiding these complications. And the lesson here is to treat the disease early as possible for the best outcome. And in order to do that, as we discussed, we need to identify these patients early. We're going to shift our attention next to talk about the gene HLA-B27, as well as some of the cytokines that are involved in axial spondyloarthritis. So HLA-B27 is a gene on chromosome arm 6p that includes MHC class 1, and it displays antigens on antigen-presenting cells. For many years, we presumed that, like many other autoimmune diseases, including rheumatoid arthritis and lupus, that the development of autoimmunity and spondyloarthritis was actually antigen-dependent. The arthritogenic peptide hypothesis suggested that HLA-B27 might actually have a tendency to present certain bacterial and viral antigens to CD8 T cells. And this would then cause the T cells to become autoreactive to joints and soft tissue. However, this hypothesis has actually fallen out of favor due to a number of arguments. Firstly, that genetic factors seen in classical autoimmune diseases like rheumatoid arthritis and lupus are not present in spondyloarthritis, and that there is a lack of female predominance as there are in those other conditions. Also, there are no disease-specific antibodies like the rheumatoid factor and the ANA that we see in patients with this condition. So since then, it's actually been identified that HLA-B27 has two unique attributes that might lead to a non-antigen-dependent approach to the pathophysiology. The first is that it has a tendency to dimerize, and the formation of these structures may actually stimulate natural killer cells and other cells of the innate immunity to release cytokines. The second unique attribute is that HLA-B27 is a little bit more unstable. And when it's formed in the endoplasmic reticulum, it can actually misfold and lead to what's called an unfolded protein response. This leads to the release of IL-23, which then triggers Th17 cells to release IL-17. A cytokine that we're going to discuss in a little bit is central to the pathogenesis of spondyloarthritis. So in addition to the two attributes of HLA-B27, it's also been noted that additional proteins involved in the production and display of HLA-B27, as well as peptide handling for HLA-B27, may also be affected in this condition. So in the endoplasmic reticulum, the aminopeptidase ERAP1 actually trims antigens in preparation for presentation by HLA-B27. And we think that this may be affected in the condition based off of additional studies that we've seen. Also, IL-23, in addition to ERAP1, are also involved in HLA-B27's handling in peptides, and it's been seen that genetic alleles are associated with this condition as well, too. We still don't have a complete picture about the pathogenesis of spondyloarthritis, but in 2007, genome-wide association studies actually identified 41 additional haplotypes, mainly involved in the innate immune system in patients with axial spondyloarthritis. Shifting gears a bit to look at cytokines, it has been long known that tumor necrosis factor alpha plays a central role in synovitis, enthesitis, bone destruction, and gut inflammation. However, it's also discovered now that IL-17 actually has very similar effects. It has also been found that IL-22 concurrently, but independently, may lead to the production of abnormal bone. There are a lot more complexities than the diagrams I'm showing you here, but these are the big picture. So in summary, early treatment of axial spondyloarthritis may prevent bone formation and complications. Axial spondyloarthritis lacks pathophysiologic features of classical autoimmune disease and involves a greater degree of innate immunity than we had previously identified. HLA-B27 dimerization and misfolding may actually trigger inflammation in a non-antigen dependent manner. And TNF-alpha, IL-17, and IL-23 play a prominent role in inflammation, while IL-22, on the other hand, may contribute to bone formation. So I want to shift gears for the rest of this talk to focus on the treatment of axial spondyloarthritis. We take a multimodal approach, which includes non-pharmacologic measures, including patient education and physical therapy. And then we also employ the use of pharmacologic agents, including non-steroidal anti-inflammatories, which are first line in the treatment, and other treatments, including intra-articular corticosteroids and biological drugs, which we'll discuss in further detail down the line. Finally, we should not ignore additional measures that we can take to prevent comorbidities, including cardiovascular disease. So it's extremely important in these patients to treat traditional cardiovascular risk factors, including hypertension, dyslipidemia, smoking, and diabetes. So in regards to patient education, Spondyloarthritis is uncommon enough that the patient who has it may not know any other patient with the diagnosis. That is, unless they have a relative with the condition. But because of that, we want to make sure that they understand the pathogenesis about the condition, the clinical manifestations, and what we expect out of the disease course. They need to know that we're not just treating their pain, but that we're treating the inflammation to prevent the development of the disease progression, the stiffness, and all of these other comorbidities that are associated with the condition. We also discuss the details behind physical therapy, how to best cope with the disease, and the expected financial burden of the disease for them. A recent study actually showed that a 2-hour information session led to more frequent exercise and improvement in pain and quality of life in these patients. And so it can make a large impact on outcomes just to invest a little bit of time in the beginning to discuss these factors. Moving on to physical therapy. So physical therapy for our patients consists of low-intensity stretching exercises that basically aim to prevent and slow the development of spinal mobility. Patients are also instructed to perform breathing exercises to preserve their chest expansion. And there's actually been physical therapists who actually apply pressure on top of the chest of the patient when they're lying down and provide resistance exercises for their breathing. They're designed to improve not only pain, but also function and stiffness. Exercises should be done at home on a daily basis after they've completed a formal physical therapy course of sessions. And then in patients who struggle with a lot of pain and stiffness, they can often take an extra dose of NSAIDs prior to their home physical therapy exercises in order to allow for full mobilization of the exercises when they're at home. So low-intensity flexibility exercises are known to be very effective, but how about high-intensity endurance and strength exercises? Are they just as effective? Could there be an added benefit of cardiovascular disease prevention in this group of patients? So this was actually looked at in a Norwegian study in 2014. They took 28 patients with axial spondyloarthritis, and they randomized them into an exercise group and a control group. And the exercise group included getting them either on the treadmill for 40 minutes or doing 20 minutes of strengthening exercises, which included bench press, squats, planking exercises. They did this anywhere between 2 to 3 times a week. And then they looked at these patients down the line. They also excluded patients that had underlying cardiovascular disease. And you would think that this sounds like a pretty intensive exercise, right? How many patients can actually accomplish this? But the reality is, if you look at the demographics in their group, most of these patients were older folks. They were in their 40s. And most of them had had the disease for a very long time, 25 years or longer. And it was found that actually there was a significant change in the disease activity and function compared in the exercise group to the control group. And then it was also found that arterial stiffness, which is a measure of cardiovascular risk, was actually significantly improved in the patients in the exercise group based off of the augmentation index and the pulse wave velocity. Also, VO2 peak, which is a measure of cardiorespiratory fitness, the waist circumference, total fat, and abdominal fat were also significantly improved in the exercise group of patients. So all in all, these were pretty interesting results, and they warrant further larger-scale studies for further evaluation. How about aquatics-based physical therapy versus land therapy? So this was a Turkish study in 2014 that compared hydrotherapy versus land-based therapy among 69 patients. And it found that pain and function were superior in the hydrotherapy group compared to the land-based group. Indeed, water may actually have additional benefits. The idea is that warm water might actually relax tight muscles and allow for greater mobility during the exercises. Water reduces the effect of gravity, so these patients can stay upright more easily. And then water actually also functions as a shock absorber, reducing the pain during the exercises. So in summary, patient education and daily physical therapy play key roles in the non-pharmacologic management of patients with axial spondyloarthritis. High-intensity strength and endurance exercises may actually lead to further improvement in disease activity and pain, and could also provide an additional cardiovascular benefit in these patients. Hydrotherapy may have a greater effect on pain and function than land-based therapy. Moving on to talk about pharmacologic treatment, we'll begin by discussing the nonsteroidal anti-inflammatory drugs. nonsteroidal anti-inflammatory drugs came into widespread use in the 1950s, and there are many formulations that are FDA approved for first-line treatment of ankylosing spondylitis in particular. They are also used off-label in other forms of axial spondyloarthritis. They exert an anti-inflammatory effect primarily through COX-2 inhibition, and they lead to at least a partial response in about 75 to 80% of patients. However, it's important to keep in mind that they're not without their risk of side effects. And in terms of severe side effects, such as bleeding in the GI tract, there's a 1 to 3% chance of risk when you look at non-selective NSAIDs. And in terms of the risk of thrombosis, there's a 1 to 2% chance of risk in all NSAIDs. We'll review several NSAID studies today to look at the efficacy of the NSAIDs, the response based off of disease duration. We'll also look at some head-to-head trials comparing different types of non-selective NSAIDs. We'll also look at some studies comparing non-selective NSAIDs against COX-2 selective NSAIDs. We'll look at the differences between continuous use of NSAIDs versus on-demand use of NSAIDs, and particularly with their effect on radiographic progression. Finally, it's important to keep in mind that most of these studies were actually done in ankylosing spondylitis. Keep in mind that these drugs have been out since the 1950s, and this new classification for axial spondyloarthritis wasn't made until 2009. So a lot of these studies were done in those groups, but we'll talk in a little bit why that may or may not matter. So investigators in 2010 retrospectively looked at data in 2 randomized controlled trials of about 800 patients with ankylosing spondylitis to answer the question, do NSAIDs just treat pain, or do they also treat inflammation and have an impact on function and disease activity? And it was actually found, looking at combination of non-selective and COX-2 selective NSAIDs versus placebo, that there was indeed an improvement in all of these factors. So NSAIDs were found to improve inflammation, function, disease activity, and pain. Investigators also wondered whether or not the disease, early disease in particular, may have a greater response to NSAIDs. In this 2014 study called the INFAST study, investigators identified patients with early axial spondyloarthritis defined by a diagnosis of less than 3 years. They used a primary endpoint of the ASAS partial remission. ASAS is an international group of experts that study spondyloarthritis. And this ASAS partial remission actually requires a composite of individual measures, including a questionnaire for patients' global assessment of how active their disease is, an assessment of pain, function, and inflammation. And all of these measures had to be very low in order to meet a criteria of partial remission. So this was a very rigorous endpoint, and it was actually found that in the group of patients, in this group of 51 patients, using only naproxen, that 35% of these patients actually resulted in having partial remission when using only NSAIDs. So these were actually very impressive results that suggested that early disease might actually be more responsive to nonsteroidal anti-inflammatories. So we'll come back to this study later when we discuss biological drugs to look at the other half of these patients. Next, we'll talk about some head-to-head trials between different non-selective NSAIDs. And there have actually been several. Between the 1970s and the 1990s, there were 12 randomized controlled trials that compared indomethacin against various other non-selective NSAIDs. And then there was also a study in 1980 between 2 non-indomethacin NSAIDs. And then finally, in 2014, there was a Cochrane review of 39 studies comparing various different NSAIDs. And all of these patients actually didn't have any difference, no matter the choice of the NSAID that they were using. So when it comes to treating our patients, we don't have a particular preference. It ultimately depends on the tolerance and any particular allergy that the patient might have that we would avoid certain medications. I want to point out again that axial spondyloarthritis and the definition of ankylosing spondylitis have varied over the course of time. And prior to the 2009 classification, the previous classification criteria for ankylosing spondylitis in particular was in 1984. So prior to 1984, the diagnosis of ankylosing spondylitis was more loose than it was after that. And you might be able to appreciate that a lot of these studies done in the 1970s and early in the 1980s probably included patients with axial spondyloarthritis with other forms, even though they were defined as having ankylosing spondylitis. So I feel that a lot of these studies can actually be applied more globally to address all patients with axial spondyloarthritis. So what about COX-2 inhibitors versus non-selective NSAIDs? So this is a 2001 study looking at 6 weeks of information comparing celecoxib and ketoprofen against placebo. And you can see that both ketoprofen and celecoxib had a similar impact in terms of relief of pain in these patients, seen in the left figure. And then on the right figure, that celecoxib may have had a slight advantage compared to ketoprofen in terms of the effect on function. This was a relatively short study, and it's hard to make any generalizations about this study. A more recent randomized clinical trial in 2016 actually compared 2 different doses of another COX-2 selective NSAID called atoricoxib against naproxen in ankylosing spondylitis. These drugs were found to be non-inferior to each other. Atoricoxib isn't available in the United States, but it's just another study that demonstrates that there may not be a significant difference between these 2 different classes of NSAIDs. How about the effect of continuous and on-demand NSAIDs, in particular on radiographic progression? So this is a 2005 randomized control trial that examined patients on scheduled dosing versus on-demand dosing for their pain and examined the effect on their radiographic changes by the end of 2 years with these 2 different regimens. And I purposely made these figures small because I really just wanted to show you the big picture, that despite the type of dosing, whether or not patients were on continuous dosing versus on-demand dosing, there was actually no difference in the measured disease activity, pain, inflammation, or a questionnaire on their global assessment of disease. So what happened to radiographic progression then? So it turns out that the patients that took on-demand dosing actually had a more rapid progression in their radiographic changes compared to patients on scheduled or continuous dosing. And a post hoc analysis done 7 years later actually found that this effect was most pronounced in patients who had a baseline elevation in their ESR or their CRP. A more recent study in 2016 actually re-examined this question using the non-selective NSAID diclofenac. And they actually found no difference between the 2 groups. So in the end, I think the question is a little bit difficult for us to answer. So in summary, NSAIDs provide a variety of measures. They improve a variety of measures, including inflammation, function, disease activity, and pain. Patients who have early disease have a good chance of responding quite well to NSAIDs. There's no differences in the efficacy between non-selective NSAIDs, and then no clear-cut differences in the efficacy of COX-2 versus non-COX-2 selective NSAIDs. Continuous NSAIDs may reduce radiographic progression, particularly in patients with elevated inflammatory markers, but ultimately we decide which one to use based off of weighing the side effects and the benefits in the individual patient. Other anti-inflammatory agents include methotrexate, leflunomide, sulfasalazine, and oral corticosteroids, but these drugs actually lack efficacy in axial disease. They can be considered if the patient with axial spondyloarthritis also has evidence of peripheral arthritis. Otherwise, we don't tend to use these drugs very much. Intra-articular corticosteroids are a difference, however, and they can actually be used acutely for injection for sacroiliitis as well as certain cases of enthesitis. We try to be selective for enthesitis because we don't want to inject areas that are prone to risk of rupture. So when NSAIDs are unsuccessful or if they're contraindicated in your patient, we often consider the use of biological drugs. So biological products, by definition, are derived from living organisms, including humans, other animals, and microorganisms. And in non-rheumatic disease, these might include vaccinations, blood products, antitoxins. But in rheumatic diseases, we actually use primarily monoclonal antibodies and fusion proteins. So when you compare a biological drug against a conventional drug, the complexities of a biological drug are pretty wide compared to a conventional drug. And to give you an example, infliximab, a drug that we use, actually has this chemical formula. So it contains thousands of carbons, hydrogens, nitrogens, and oxygens. And so the complexity of even creating these drugs is quite difficult. If they're taken in by mouth, they're actually going to be destroyed by the digestive tract. So they're actually either given by subcutaneous injection or by intravenous infusion. Although they don't have side effects of gastrointestinal bleeding and thrombosis, there are a number of other side effects that we want to watch for in patients that are receiving these. And these include local site reactions, neutropenia, demyelinating disease, opportunistic infections, and certain kinds of skin cancers as well. If you recall that TNF-alpha and IL-17 play a central role in inflammation in spondyloarthritis, then you're actually not going to be surprised about the biologics that we use. And so there are currently 5 TNF-alpha inhibitors that are approved for ankylosing spondylitis. The first was approved in early 2000, and the others have followed. And these include adalimumab, infliximab, etanercept, golimumab, and certolizumab. And they all have slightly different structures. Most recently, secukinumab, an IL-17A inhibitor, was approved in 2016. All 6 of these drugs are FDA approved for the subsets of ankylosing spondylitis and psoriatic arthritis. They are not FDA approved in general for axial spondyloarthritis. However, there are ongoing trials looking at the application of these drugs in non-radiographic, specifically, forms of axial spondyloarthritis. In addition, if you recall that IL-23 is theorized to release antigen-presenting cells due to HLA-B27 misfolding, you would also understand the utility of an IL-12/23 inhibitor called ustekinumab. This was approved in 2013 for the diagnosis of psoriatic arthritis. So it's quite known that the efficacy of biologics have been well established in certain forms of spondyloarthritis. Investigators also wanted to know whether early treatment using combination therapy with a TNF-alpha inhibitor and a nonsteroidal anti-inflammatory might actually lead to a greater improvement in the partial remission in these patients. So going back to the INFAST study, 105 patients were treated with combination infliximab and naproxen, and 62% of those patients actually achieved partial remission. And these were impressive results in the world of spondyloarthritis. 51% of patients actually had completely inactive disease at the end of 28 weeks of the study. So in patients with early axial spondyloarthritis, combination infliximab and naproxen might actually lead to increased frequency of remission. Next, due to some promising results, particularly in the world of rheumatoid arthritis, the investigators also wanted to know whether or not early treatment would actually alter the natural history of axial spondyloarthritis, such that patients might not actually require long-term biologic therapy. So they took the patients that achieved partial remission in part 1 of this study. There were 82 of them. And then they randomized them either to receive naproxen or no treatment. And then they followed them throughout the rest of the year. And it turns out that regardless of whether patients were switched to naproxen or no treatment, 40 to 47.5% of them actually remained in partial remission after being 6 months off of biological therapy. So this was groundbreaking research that suggests that if we recognize and treat disease early and aggressively enough, we might actually be able to alter the trajectory of disease in these patients without them actually requiring long-term treatment down the line. So there's certainly going to be more studies about this in the future, and certainly more to examine a potential solution, long-term solution in these patients. I want to make a final note regarding biologic therapy and vaccinations. There are 3 illnesses that we want to vaccinate for, and this includes influenza, pneumococcus, and shingles. Patients who are on biologic therapy should receive annual inactivated influenza vaccination. And going back to that point, comparing between the high dose and the standard dose, the CDC has not in particular recommended a preference for one of these doses over the other in immunosuppressed patients. Looking at pneumococcus, there's 2 different vaccinations, and both of these vaccinations should be received by patients on biological therapy. And then depending on which one is done first, a different vaccination schedule should be done in either case. Finally, shingles. Up until October 2017, our only option in terms of vaccination of shingles was a live attenuated zoster vaccine, and it had to be administered 4 weeks prior to initiation of biologic therapy. However, I'm pleased to say since October 2017, there's actually a new recombinant zoster vaccination that's available. It's approved in adults aged 50 and plus compared to the previous vaccination, which is adults aged 60 and plus. It's administered as 2 intramuscular injections and is given anywhere between 2 to 6 months apart. So this was also a really useful development for patients who are on any form of biologic therapy. So in summary, biological agents are effective as second-line treatment against certain forms of spondyloarthritis, particularly in ankylosing spondylitis and psoriatic arthritis. There are ongoing studies looking at the application of these biological drugs in non-radiographic axial spondyloarthritis. And early treatment with a TNF-alpha inhibitor and NSAIDs is highly effective and may actually alter the natural history of axial spondyloarthritis. Patients should be vaccinated against influenza, pneumococcus, and shingles. I want to finish our talk today by discussing a new group of biologics that are currently under development. These are called biosimilars. And the history actually dates back to 2010, when the Biologics Price and Competition Act was passed under the Affordable Care Act. And it basically created an abbreviated licensure pathway for biological products shown to be biosimilar to an FDA-licensed product. And by biosimilar, that means that there's no clinically meaningful differences in terms of the safety, the purity, and the potency of these drugs. The purpose of enacting this act was to lower drug prices, lower healthcare costs, and overall improve access to medicine, much like what the rest of the Affordable Care Act was aimed to achieve. So companies would need to develop their own manufacturing processes, which would likely involve different cell lines from the original product, incubation periods, different kinds of purification processes, and the FDA really wanted to abbreviate it so that they could get these drugs faster out on the market. So in order to demonstrate biosimilarity, companies needed to show analyses including structural and functional analyses. By structural analyses, the proteins actually had to have the same amino acid structure as the original product, possibly with some differences in terms of maybe early cutoff and over the N or the C terminus. They could have differences in tertiary and quaternary modifications like glycosylation or deamidation, but the primary structure had to be the same. Then they had to do animal and clinical studies to look at toxicity, pharmacokinetics, pharmacodynamics, and immunogenicity. Finally, comparative clinical studies between the candidate biosimilar drug and the reference drug needed to be completed in order to demonstrate that they were equivalent or non-inferior to each other. An important point here is that they actually couldn't demonstrate superiority because that wouldn't meet the definition of biosimilarity. So this is a very key point. So biosimilars can be approved for multiple disease indications, even if clinical studies only included patients with one indication. And this actually happened recently in the infliximab, one of the infliximab biosimilars. So the drug was studied in ankylosing spondylitis, and it was also studied in rheumatoid arthritis. It's now approved for 6 different indications, including psoriatic arthritis, ulcerative colitis, Crohn's disease, and psoriatic arthritis as well too. So you can imagine that some specialists might have some hesitancy about being the first one to use these drugs in their patients. And I think, the reason why they probably instituted this rule is that they wanted to make sure to get these drugs out on the market in a fairly rapid fashion. And then on the other hand, if you look at it, post-marketing studies will actually give us some more data regarding the effectiveness of these drugs. Finally, I also wanted to point out the concept of interchangeability. This is a different term that requires a separate FDA approval. And it basically requires that the switching between a biosimilar drug and a reference drug doesn't actually alter the safety or the efficacy of the drug. And it requires additional, more rigorous studies. So it requires a switching study where you want to switch the patient from a reference drug to a biosimilar drug, and then from a biosimilar drug back to a reference drug, without demonstrating a difference in the safety and the efficacy of these drugs. The key thing here is that biosimilars that get an FDA approval as interchangeable can actually be substituted for the reference product without the consent of the healthcare provider. So the pharmacist could make this switch, for example, once a drug has been approved to be an interchangeable drug. None of the currently FDA-approved biosimilars have received this classification, so none of the ones that are currently out are interchangeable. But this is going to be something that we're going to be seeing in the future. So how much competition has this actually generated? The first biosimilar drug was approved for the world of hematology in September 2015. It was a biosimilar to filgrastim. And biosimilars, by convention, are named after the original or the reference drug. And then they contain a 4-letter suffix that doesn't really have any sort of meaning behind it. So over the course of the past 2 years, there have now been 6 biosimilars approved for rheumatic diseases. We do not yet officially see all of these out on the market yet, but they're coming soon. And both we and the patients will have to address and face these changes. So certainly competition has increased. The marketed price of some of these new drugs are lower than the reference product. But I think because of the complexities of our healthcare system, it's yet to see whether they truly lower the overall drug costs for the patient, whether they lower healthcare costs, and whether they improve access to medicine. However, I think if they're successful in the end, it would be life-altering, not only for patients with axial spondyloarthritis, but for all patients who require biologic therapy, regardless of their diagnosis. So I hope I've been able to give you a greater understanding of axial spondyloarthritis. Please consider this in your patients, both men and women. We now have many treatments, and there are many more coming, as we've talked. And we can use these drugs to more fully treat the disease. The key is getting these patients referred early for treatment so that we can alter the trajectory of their disease. Thank you very much.
Wow. What a great presentation. I'll ask you to call on the audience and please repeat the questions.
Yes. Yes, that's a good question. So the question is, patients who have inflammatory spondyloarthritis, can they have sacroiliitis, or maybe they have them at different locations? So ankylosing spondylitis is kind of our classical prototype for this condition, and the inflammation always starts at the sacroiliac joints and then travels upwards across the spine in that condition. But in the other 4 forms of axial spondyloarthritis, you may or may not have sacroiliac involvement. Yes.
NSAIDs seem to have a bad rap reputation these days. And so you have a person with inflammatory bowel disease and heart block who's seen a GI specialist and a cardiologist. And you're saying he should be on an NSAID. How do you reconcile this problem when they say absolutely no NSAIDs?
I mean, absolutely. So the question is, what do you do in a patient who has inflammatory bowel disease or cardiovascular disease when it comes to nonsteroidal anti-inflammatories? And the reality is we do have to consider it. In patients who have the enteropathic form of inflammatory arthritis, we do limit the use of nonsteroidal anti-inflammatories. In patients who have relatively inactive disease, for example, they may have proctitis that hasn't been very active, they may have more limited disease, it's important to work with the gastroenterologist to decide on the utility of possibly considering infrequent dosing of NSAIDs. And certainly we work with our cardiologists as well to decide on whether or not certain forms of NSAIDs like naproxen may not be just relatively contraindicated. But often you're absolutely right. We really have to think about the second-line agents in those conditions like the biologics. Yes. That's a very good question. Yes, so the question was whether or not continuous or on-demand NSAIDs actually led to a difference in terms of side effects. And in the first study that I showed you, the 2005 study, they did notice a difference actually, and that was a study using celecoxib. And even with celecoxib, they did notice a difference in terms of GI side effects. It was not clinically significant, but you could argue that the study wasn't, the sample size wasn't designed to detect statistically significant differences. And so that's a very real concern in our patients. Yes. Mm-hmm.
That was a really nice review. So as we begin to move up our lead time to treat people that we have with other diseases, are there some that have self-remitting processes that could be used as a chronic disease? And are there others that differentiate and discover mimickers later on when the disease is not spondyloarthritis, or is one of these spondyloarthritis?
Mm-hmm. So the question was whether or not some of these patients who present with these symptoms may actually have a self-limited form of the disease. And I'm sorry, what was the second half of your question?
And then others who indeed have disease there, do they have something else later on? Whipples, CBD, CBPD, other things that could present with spondyloarthritis?
Okay, so the other part of the question is whether or not there may be a mimic causing their symptoms. And so to answer the first question, that is often why we almost require that our patients have at least greater than 3 months of active disease, suggesting that this is a chronic process. So we do try to separate out the patients that have perhaps an earlier presentation. We may view them a bit differently, approach the treatment differently, but all in all, most of the patients that we see have longer standing symptoms that we don't expect to remit over time. And in answer to your other question, whether or not there could be mimics of disease, whenever I see patients in clinic, I often categorize them into the degree of suspicion that I have for axial spondyloarthritis. So if a patient has defined MRI or X-ray findings, my suspicion that they definitely have that diagnosis is really high. I might take a different approach to a patient that doesn't have proven imaging findings in terms of whether I might reevaluate that patient for a different condition. Yes?
So, getting back to the cardiovascular risk, I guess from your talk, it sounds like you imply that perhaps a decline in circulation perhaps contributed to increasing cardiovascular risk. So, the first question I have is that correct interpretation? The second part is there any evidence that more targeted disease-modifying therapy, like looking at techniques that for example, any manifestation that might actually be also positively impacting increasing cardiovascular risk?
Okay, so the question is whether or not the risk of cardiovascular disease in these patients is closely tied with the inflammatory nature of the disease. I'll answer that question first. Kind of taking a step back and looking at all autoimmune diseases, including lupus and rheumatoid arthritis, if you look at all of these patients with inflammatory conditions, it does seem that when you individually look at the inflammatory components of how active their disease are, patients who have more active inflammation do demonstrate a higher frequency of cardiovascular disease. So when it comes to generally speaking, that risk does seem to be elevated. Specifically in ankylosing spondylitis, I think that's been more suggested, but probably not as many complete and multitude of studies to say that for 100% certain. And could you repeat your second question again?
The second question is, if that's the case, any of the targeted disease-modifying therapies that are now becoming more online, including potentially cardiovascular risk factors?
Yeah. So the question is whether or not the drugs that are targeted towards axial spondyloarthritis, could they potentially decrease the risk? And that is our hope, that is our expectation. That hasn't specifically been looked at, I think, long enough because a lot of the trials that we use, the longest trials are usually about 2 years, and that's probably not enough to make identifications about the true effect on the risk. But that is the presumption that starting these medications, treating the inflammation, does overall reduce the risk of cardiovascular disease.
I'm afraid we're going to have to cut the discussion short. The hour is at hand. I want to thank Dr. Lin for just an outstanding medical grand rounds.